Agoraphobia. In agoraphobia, there is fear of open spaces and related aspects such as the presence of crowds and difficulty of immediate, easy escape to a safe place. Commonly, there is fear of leaving home, shops, crowds, and public places, or of traveling alone in trains, buses, or planes. Agoraphobia is commoner among females. Assessment of agoraphobia. Situations which makes the person anxious becomes anxious in situations from where escape might be difficult, for example, being outside the home alone, being in a crowd, or traveling by public transport. Feels anxious that help may not be available in the event of having an unexpected or panic attack or panic-like symptoms. Careful questioning will reveal that, in agoraphobia, patients do not avoid social contact, but they fear being away from home. Anxiety symptoms experienced. Common physical symptoms experienced are sweating, dizziness, dry mouth, palpitations, and tremor. In addition, patients also experience a subjective feeling of anxiety. Many also experience panic attacks in such situations. Record duration and progression of symptoms over time. Coping mechanisms and impact. Patients with agoraphobia experience less anxiety when accompanied by another person. They may escape from anxiety-provoking situations and avoid situations causing anxiety. Some patients may not go out of the house at all. This can lead to severe impairment of normal functioning. Differential diagnosis. Differentiate agoraphobia from depression, social phobia, or schizophrenia. Patients may have comorbid depression or panic attacks. Management of agoraphobia. Management consists of graded exposure, a behavior therapy, effective in the treatment of phobias, cognitive therapy which addresses beliefs which maintain the phobia, and pharmacotherapy. Determining the goals of treatment. The goals depend on the current disability and the needs of the patient. A patient with agoraphobia may want to be able to travel alone by bus, or go out shopping to a supermarket. Educating the patient. Persons with phobia experience severe anxiety when they encounter a feared situation. If they remain in the situation, the anxiety will peak and last for about 30 to 45 minutes and then subside. They generally do not remain in a feared situation long enough for this to happen, and often leave the situation as soon as they experience anxiety. This reduces the anxiety but maintains the phobia. In graded exposure, the patient is exposed to phobic situations. The patient remains in the feared situation until the anxiety reduces, instead of escaping. With repeated exposure, the anxiety gradually diminishes until it no longer bothers the patient. This will only occur if each session exposes the patient for an adequate duration. If the exposure is terminated before the anxiety reduces to a negligible level, the phobia is maintained. Following is an example on educating a patient with agoraphobia. You experience fear, sweating, and palpitations when you go out of the house alone. These are anxiety symptoms. Although other people do not experience anxiety in similar situations, because you have an exaggerated fear of certain situations, you experience these symptoms of anxiety. When you experience these anxiety symptoms, you think it is an indication that you are going to faint. This increases your anxiety, which in turn causes you even more anxiety. Therefore, you avoid such situations. This avoidance maintains the phobia. The aim of treatment is to break this vicious cycle. During treatment, we will gradually expose you to situations which cause you anxiety until you are no longer fearful of these situations. Developing a hierarchy. The patient lists all the situations which he fears. This includes situations which are avoided completely as well as those which cause a mild degree of anxiety. The list should be as detailed as possible. The patient may need prompting to identify anxiety-provoking situations. These are then ordered as a hierarchy. The patient rates on a scale of 1 to 10 the degree of anxiety caused by each situation, and then arranges the situations from the least anxiety-provoking to the most anxiety-provoking. In agoraphobia, the hierarchy could consist of walking to the bus stand and waiting for a bus, traveling in the bus with the companion seated separately, traveling in the bus alone, and shopping in a crowded market. Graded exposure. The hierarchy of anxiety-provoking situations is used in carrying out graded exposure. Exposure should be graded, repeated, and prolonged. Therapy sessions usually last about 45 minutes. The exposure can initially be carried out in the therapy sessions. This allows the patient to learn self-monitoring and the importance of adequate duration of exposure. After carrying out exposure with the therapist, the patient is requested to carry out the exposure daily as a homework task. A family member can be trained to act as a co-therapist to encourage the patient to carry out exposure at home. Exposure should begin with the least anxiety-provoking situation. Exposing patients to situations which do not provoke anxiety is of no benefit. If the patient has no anxiety when accompanied by someone, she should not be accompanied by another person during exposure sessions. Self-monitoring is carried out when the patient is exposed to feared situations. Once the anxiety level comes down to an insignificant level, the patient moves on to the next step in the hierarchy. Self-monitoring. The patient rates on a scale of 1 to 10 the degree of anxiety caused by each situation. The level of anticipatory anxiety before the event and the actual anxiety during exposure is recorded. During exposure, patient monitors anxiety at the start and how it reduces with time and rates the anxiety experienced at the end of exposure. Exposure and self-monitoring is done daily and records are reviewed at follow-up.